ladies and gentlemen. Thank you so much for joining us. We now are going into our panel discussion, Targeting Cancer, the impact of genomic testing from prevention to treatment. So again, a very timely and significant topic area. To moderate this, again, may I please invite on stage a gentleman who's graced the M42 stage for us at Arab Health. You've seen him here earlier today, so we're in very good hands. Albara Elkani, Senior VP Operations at M42. Please do join me on stage. Albara, thank you so much for your patience. I know that we're running over time, but we're going to give you a little bit of extra time. And between us, let's introduce our guests and get them on stage for this wonderful panel discussion.
Sure. Thank you so much, Mandeep. First of all, I'd like to introduce Dr. Azza Atiya, a colleague of ours at M42, and she's the head of clinical genomics. Thank you, Dr. And also, please, our esteemed colleagues from Cleveland Clinic Abu Dhabi, Dr. Stephen Gabrai, the Institute Chair in Medical Oncology and Hematology. Also from Cleveland Clinic Abu Dhabi, our dear colleague, Dr. Fawad Khan, who is responsible for the Hereditary High-Risk Cancer Program lead. And last but not least, our colleague from the Department of Health, Dr. Sahar, is also responsible for the genomics strategy at the Department of Health.
Thank you. Go for it.
Please. So maybe let's just set the stage again. I think it's important to, while we've got all our experts here and clinicians from the field, it's also good to understand where we come from and where we're moving forward. So maybe this is an opportunity to really ask Dr. Azza to describe to us how we started off the population genomic program, and then we'll move into how we've now come into a new frontier when it comes to precision medicine and in particular to oncology. So Dr. Azza.
Thank you, Albara, for the question and for inviting me. So we started, in fact, by the Emirati Genome Program in M42 or in G42. And then we started with Dr. Grobmeier and the Cleveland Clinic, a pilot study for 40 patients who were high-risk patients complaining of breast cancer or ovarian cancer or other types of cancer, for whom we tested for 47 gene panel. And we detected about 8 out of 40 patients, which is a big percent, having a highly penetrant mutation and hence need a specific treatment according with a precision medicine and target therapy according to the mutation. Then once this pilot was very successful because we were able to deliver results in only 7 days, which never happened anywhere regarding genetic results when it comes to whole genome sequencing, because we had already the data of these patient sequence. So once we get the result, we hand it over to Dr. Grobmeier and his team, and this patient gets the right treatment at the right time, and I think they had a better outcome. Then after the pilot, immediately we started the program itself, and then we have now more than 500 patients already diagnosed and for whom genetic test has been done. So I think it's a big shift in the progress of the diagnosis and management of patients.
Thank you, Dr. Azza. Just to give some context as well, genomic testing, and Dr. Grabmeier will attest to this, was not readily available for anyone really in Abu Dhabi. I.e., if there's a requirement for genomic testing, it would have to be typically paid out of pocket and then sent to a lab abroad, and then you'd wait weeks and weeks for the results to come back. A small statistic, in 2019, there was approximately 5,000 genomic tests ordered in the Emirate of Abu Dhabi because of the lack of infrastructure, lack of sort of reimbursement and genomic data. So far this year, we anticipate to hopefully perform over 35,000 clinical genomic diagnostic tests. That's to give you a context of this pilot, how it led to us being in a position where we're able to freely provide clinical genomic testing to the entire Abu Dhabi. So Dr. Grabmeier, on that note, can you please maybe just give us your insights onto how we've moved from population genomics into precision medicine, specifically for the oncology, outside of that particular pilot study that we did.
Thank you, Albara. It's been a very exciting journey over the last almost 5 years, and working with great partners like we have at M42 has been phenomenal. Being able to serve patients with genomic sequencing done right here in Abu Dhabi has been also a big win for the doctors and the patients. The other thing that's really impressed me is the impact the program has had on the acceptance of genetic testing. And I can safely say that when I arrived, maybe 20% of the patients we sent for genetic counseling would follow through with testing. And I think the Emirati Genome Project and awareness of the importance of genetics has changed all of that. And I think probably now it's closer to 90% of patients. Now it's closer to 90% of patients that we refer for counseling go through with testing. And it's really, I think, a tribute to the success of the Emirati Genome Project. Looking to the future, we're about to launch a program where patients, regardless of their family history at a young age, can come and seek counseling and testing. So this really fulfills the vision of Mary Claire King, who suggested a long time ago that we should be testing patients before they develop disease, not after. And so we're on the verge of launching that with the support of the Department of Health, and it's something we're very excited about and hope to have this on scale for the residents and the citizens of Abu Dhabi in the near future.
Thank you, Dr. Stephen. Dr. Fawad, one of the major elements that I think the ecosystem feels is quite important is to look at prevention from a genomic aspect. And we see it in maybe a two-pronged approach. One is to obviously look at germline, hereditary, what you inherit as a risk of disease from your parents. And the other one is to look at potential risk of somatic or cancers that you develop over the years. So could you give us your thoughts on what you see, what we call the liquid biopsy as a screening tool, and how that can be really utilized in prevention within cancer?
Thank you. So we've been very fortunate at Cleveland Clinic Abu Dhabi to offer a hereditary high-risk program, which is one of its kind to the region. And we are also very fortunate to have over 400 high-risk patients who are being offered personalized precision prevention care in our clinic. So we have mainly been using genomic information in planning and offering care to these patients. We haven't yet used the liquid biopsies, which I believe is still something that is, I think, of great interest, and there's a lot of research going on, and I think there's a lot of work going on at M42 on it. But our focus has been to identify patients at increased risk of cancers, put them on a prevention program, and genomics has really revolutionized that. Previously, it was without genomics, it was mainly based on personal and family history. With genomics, it's now changed into a more personalized and precision program, just to give you an idea. I think Dr. Grobmeyer has been doing a lot of work on the liquid biopsy, so he'll be able to give you more details.
Thank you.
Yeah, just want to add to the liquid biopsy story. What I'd like to focus on is the need to implement these kind of things. And one of our jobs working here is to understand not only patterns of disease, but patterns of acceptance of screening programs. And it's great to have a screening program, but if nobody complies with your cancer screening program, it's really not doing anyone very much good. So one of the things that's been observed, and I'll give you an example, is that, and I think it applies in other areas of cancer screening, but just like in other parts of the world, we're seeing an increase in early onset colorectal cancer here in the UAE. We also realize that the compliance with colonoscopy or other types of screening tests is exceedingly low. And even of the patients who do a FIT test, only a third of them will even follow up on a positive FIT test. And so there's a very large need to develop new strategies for screening. And as you probably know, there's been some work recently published in the New England Journal looking at the value of liquid biopsies for colorectal cancer screening. Doesn't replace colonoscopy, but as a second to a patient who refuses to get colonoscopy, it can be quite effective. And so this is something we're on the verge of looking at more carefully and in discussions about how to implement that on a test population here in the Emirate.
Thank you. I think also that discussion is a dynamic discussion. I believe it's maturing in the sense of using liquid biopsies as a potential screening tool. The science is developing, the products are getting better as well. So I think this could really be a catalyst for the prevention using genomics in particular to cancer. So without sort of all of the support and the regulations of the regulator, the Department of Health, all of what we're talking about today would not be possible. And I think I'll take this second here just to really commend the Department of Health on their efforts on being very dynamic. It is extremely rare to go anywhere in the world and see a regulator work hand in hand with the healthcare providers, be visionary but dynamic and not bureaucratic. So we're very fortunate to have our regulator, the Department of Health, with us. So on that opportunity, I would like to ask Sahar a quick question regarding how is the Department of Health ensuring that genomic data is getting to the people that matter, the frontline physicians and clinicians who will utilize this to serve their communities better?
I hope that you guys can hear me all okay. So first of all, I would like to I think that a lot of what has been brought up by Dr. Azza, Dr. Grobmeyer is a testament to the great collaboration between DOH, M42, and Cleveland Clinic. In the Department of Health, we're moving away from the one-size-fits-all strategy when it comes to oncology and moving towards personalized and precision care. We recognize that breast cancer is one of the leading causes of mortality in Emirati women, and through the work that's been done by Dr. Grabmeyer, that Emirati women also tend to develop breast cancer about a decade earlier than what's seen in Western populations. So the Department of Health, we recently launched the guidelines for germline testing of breast and ovarian cancer, which is offered currently in M42. So being able to bring in something into the country and having it accessible to physicians across all the different health sectors in Abu Dhabi is something that we're striving towards. Also in implementing a precision medicine program, ensuring that patients are able to receive tailored management of their cases based off of their genetic makeup. And then if a patient was recognized to have a pathogenic variant, also testing their family members, like Dr. Azza and Dr. Grabmeyer also brought on, of enhancing prevention strategies within the Emirati population to stop patients from ever developing cancer in the first place. And in terms of equipping healthcare professionals in Abu Dhabi, we recognize the importance of giving clinicians the tools to be able to bring this into their practice. So through a collaboration with Khalifa University and Harvard University, we've enrolled physicians across multiple different fields to be able to bring in precision medicine into practice and really apply it in their work to improve overall health outcomes.
Thank you so much. That's going to really segue beautifully into my next question. Dr. Fawad, let's assume we take the 1 million Emirati whole genome sequences, and we bioinformatically screen them for what we believe to be the pathogenic variants, and we identify all the individuals that require to be managed proactively. Do you believe the clinical workflows we have today, the clinical practices we have today, and maybe lastly, the clinical infrastructure we have today can accommodate this mass population screening program managed through the clinical workflows?
I think that's a great question, and we've been preparing for this for the last couple of years under the leadership of Dr. Grobmeyer, and we've been talking with M42 and the team right when EGP started. We knew that this will be a need, a clinical need, and we are very fortunate to have, as I earlier mentioned, a precision prevention program called the Hereditary High Risk Program. We have close to 500 high-risk patients there, and these patients are managed according to the clinical guidelines, and there are 4 key strategies, prevention strategies these patients are offered, which are from enhanced screening to preventive medication, preventive surgeries, and also lifestyle modifications. We have many success stories in the last couple of years. And I have to say that we have some of the very unique genetic variants, some of very complex patients, which we have managed to provide care. And it's not just the high-risk program which is doing it. We are very fortunate to have a team of experts who are collaboratively working to manage these very complex patients. So, with M42 getting all the appropriate genomic screening, testing, with our genetic counselors to be able to appropriately interpret the results, do the pre and post-test counseling, to our multi-disease experts at Cleveland Clinic Abu Dhabi, who are not only trained but experienced to manage these complex patients. And then finally, Cleveland Clinic Foundation, where we have a very close collaboration and knowledge exchange program through multiple forums, from genetic review meetings to case conferences, where some of the high-risk programs have been running for over 10, 15 years. So collaboratively, we manage these complex care patients. Now, coming to your question, whether we are ready to take on thousands of patients, that's where we are working on, and we are hoping to grow our program as the EGP is taking shape and moving to the next stage. I think Dr. Grobmeyer might be able to expand on the future plans to grow the program, but we are certainly very capable of managing these complex patients appropriately.
Thank you, Dr. Fawad. There was a couple of very important points Dr. Fawad made, not about the program specifically, but I think the idea of collaboration. I think it's critical, first of all, you collaborate here within the healthcare ecosystem, but what's also very important is to collaborate with international partners as well. There's a lot of knowledge that has been built over years of doing similar programs, and I think rather than reinventing the wheel, it's always good to reach out to these partners. And we've managed collectively as a healthcare ecosystem to bring sort of the best practices within Abu Dhabi and manage it here under the regulated Department of Health on implementing the best form of care to our patients. So I think these are very important points. But I think if we jump on a couple of use cases to Dr. Grabmaier, maybe you can just dissect slightly what Dr. Fawad mentioned regarding the integrating of the genomic data within the clinical workflow. Do you have any real-world examples where we can see some successes that's already happened?
Every day, I can tell you. With the early onset breast cancer that we're seeing we think we're studying this now, but a significant number of patients who have germline predisposition. And so the ability to not only take care of that patient, but also have their families tested right here in the UAE is critical. But I want to emphasize one thing, which is we keep talking to the Department of Health about this, and I congratulate them on their efforts to educate, because we talk a lot about informed consent for genetic testing, and that's fine and that's important. But we also have an obligation to make sure that the healthcare system these patients enter, once they've been diagnosed with a hereditary predisposition, is equipped to take care of them. And Cleveland Clinic Abu Dhabi will not take care of every patient in the UAE by any stretch of the imagination, but we do have, working with the Department of Health, an obligation to make sure that wherever these patients land who do have hereditary risk, that they are in a safe environment. Because as we know from studies done all around the world, a lot of damage can be done over screening, over prevention. A lot of anxiety can be associated with these diagnoses. So we need to continue to work together to up the game of everyone.
100% agreed with Dr. Grabmaier. I think it's important. Well, we're fortunate that we work with people like Dr. Grabmaier and his team at Cleveland Clinic. There also needs to be a realization that the upskilling is a requirement, training and education and upskilling, and also governance through clinical workflow and oversight. These are all very critical aspects that I know our colleagues at the Department of Health take very seriously, but I think to ensure that we do things properly and the right way, we need to make sure that the systems are in place to govern this. So, excellent point. I think we might have run out of time. I'm not sure. If maybe last question before we conclude. Dr. Azza, we're churning out hundreds and thousands of clinical genomic diagnostic reports on a monthly basis. But I know that a lot of analysis is happening on the back end, what we call VUSs or variants of uncertain significance. For the audience who don't know that, that's variants or mutations that have not been linked to a disease and hasn't been published, but we're identifying these. Can you maybe just give me your thoughts on how you see VOS progressing, and do you see that with our unique population here, we might be in a position to be identifying new variants of pathogenicity?
Definitely, it's a very good question, Al-Bara. We identify especially for the rare and metabolic, and as well as for the oncology program, new variants every day. And we have a lot of VUSs, variant of uncertain significance, which are associated with symptoms in the patient. We keep an eye, we report this variant of uncertain significance according to the program, to keep an eye on those variants and to recheck on them every 6 months to be sure whether to classify them as a pathogenic or benign variant later on. But I can tell you that this will open a new perspective for the pathogenesis of the disease and for discovering new molecules and new treatment for the patients.
On that positive note, I'd like to thank our esteemed panelists for their time today, and thank you all for your patience as well. Thank you all.
Thank you so much, Al-Bara. That was wonderfully moderated yet again. And please do, yes, fantastic. Take your wonderful panel photograph. Brilliant. Ladies and gentlemen, please give our panelists a very big round of applause. Thank you once again. Thank you. We'll be back in 2 minutes for an inspirational talk with a gentleman who has a deep knowledge of this region. So bear with us just for 2 minutes. Thank you.